My name is Ian Jones, doing my end-day assignment on nasogastric tube insertion and gavage feeding for pediatric patients. So the first thing I do, I come into the room, I wash my hands, I introduce myself to the patient and the parent or caregiver that's present. I check their ID band, the child's ID band if they have one, or the parent's corresponding depending on the situation. I then explain to the mother or father or whoever it is that I need to place a nasogastric tube. It's a tube that's going to go through the nose into the stomach so that the child can receive proper feeding and nutrients. If developmentally appropriate, I'll also explain that to the child. Let them know that I'm going to be putting a tube through their nose and into their tummy so that they can eat properly, and that if they may feel a little bit of discomfort, but that once it's in, it won't hurt them at all. So I've washed my hands. I also verified the doctor's orders for placement. And I'm going to put on gloves. So for measuring, well, first off, the sizes that we were using is a 5 to 6 French for an infant, 6 to 8 for children, and 8 to 12 for adults. This being an infant, I would choose a 5 or 6 French. So there's two schools of thought on measuring the nasogastric tube appropriately. Either way, you place the child supine with the head slightly hyperflexed, nostrils pointed towards the ceiling, and then you grab your nasogastric tube and you're going to measure it by taking the end and placing that on the tip of the nose, then running it down to the bottom of the earlobe. And then you can either measure, depending, some places have different preferences, you'd have to check with your hospital policy, to the tip of the xiphoid process, or halfway between the xiphoid process and the umbilicus. So once you have that measurement, you either want to place a piece of tape there or make a mental note if there are markings of centimeter length. You don't want to mark it just yet until the placement has been confirmed. So I'm going to have the child sit up at least 30 degrees, head of bed up, for aspiration precautions. Again, if developmentally appropriate, I'll have the child assist by swallowing and tilting their head forward upon insertion. Small infants, you can have them swaddled or mummified or whatever, and for smaller children and infants, you may need to hold them, and that would actually be preferable to reduce stress and get the proper placement for aspiration precautions. So,
never mind. I'm just being special today.
Next, all that's left is insertion. So I get my nasogastric tube. If there's a stylet in place and it needs to be lubricated, I take care of that. I can either dip the tip in water or lubricant, depending. Some tubes self-lubricate after dipping in water. So I'll dip that in. I'll ask the mother or whoever to hold the baby. If it's an infant, non-nutritive sucking can really help advancement as well as reduce stress. So like a pacifier or something like this. So I would then have the patient tilt their head forward. Well, first I assess the nares for patency and select the appropriate nair, whichever one seems more patent to me. Or if they had a nasogastric tube before, I'd want to use the other nair for the insertion of the next one. So have them lean their head forward, and then I'm going to come in and I insert downwards and back towards the occiput, depending. Once I elicit a gag reflex, I stop, pull back 1 centimeter, and I'll then inform the patient, if it's a child we've prearranged, that they'll give me a signal when they feel the gag reflex, and then I'll tell them to swallow as I advance it further. And they could also, at this time, be taking sips of water if they're not NPO, and it's age appropriate. Alright, so now that my nasogastric tube is in place, and I've gotten up to my mark that I measured earlier, place a piece of tape on the nose, secure it chevron style. The next step is to confirm placement. For children as well, you'd want to put down a little skin barrier here and tape it to the cheek, and make sure there's not any excessive pressure on any of the nares. So the way that I determine placement, I have my syringe pump. This is filled with sterile water.
Like, what do you mean?
So the first method is to instill 5 millimeters or so, or milliliters of air and auscultate for a swishing sound. One thing I failed to mention is during insertion and afterwards, I'm always keeping a close eye on the respiratory rate, and if I notice any pallor or respiratory discomfort or distress, immediately withdraw the nasogastric tube as you probably entered the airway. And so now I've got my 5 millimeters of air, and I turn the stopcock on, and I instill that, and I'm auscultating for a swishing sound. Turn the stopcock off, withdraw that. Place it here. If I heard the whooshing sound, I can move on to the next phase of determining placement, which is to aspirate gastric contents. So again, stopcock off, turn it to on, aspirate until I get 0.5 to 1 milliliter of gastric contents. I've obtained that. Remove this, place it over here. Grab my pH test strips and test the pH. A pH of less than 5 is considered adequate. More than 5, it may be in the epigastric area or the respiratory tract, and that would need X-ray confirmation. Again, if there's a stylet, you want to leave that in until after X-ray confirmation. Otherwise, if you get under 5 pH, depending on hospital protocol and policy, it may be considered adequate to administer fluids and medications now, but for certain patient populations, you always need X-ray placement, so you should know your policies and procedures for that. So, now I have my tube in place. I'm going to talk about feedings and medication administration. So generally, for infants, we usually want to use, well, first off, it's small volume. You want to instill it no more than 5 to 10 milliliters over 5 to 10 minutes to reduce regurgitation. During feeding and after, you want to place the patient at least 30 degrees head of bed up, as well as possibly on their right side, they say, in Wong's, or even prone to reduce the risk of aspiration and regurgitation. So, before you initiate any feeding, the first thing you do is check placement again. So now, once placement has been confirmed, I would mark it with a marker at the tip of the nose, and that's the first thing you look for. And if that mark is not at the tip of the nose, then you know that perhaps your tube has been misplaced. And then what you do is aspirate gastric contents every time before. You're also checking residuals. The general rule of thumb for pediatric feeding is no more, if there is more than 1/4 of the previous feeding withdrawn on a residual, you hold the feeding and wait 30 to 40 minutes, or 30 minutes to an hour, and then you check again. And if it's less than 1/4, you can go ahead with the feeding. Another school of thought is by subtracting the residual, the amount, subtracting the residual from the next feed, and then refeeding the residual, proceeding with the feed, minus that amount. And again, you would need to check and see what's ordered for that. So, I've checked my residual, I've checked my placement, and now I'm ready to initiate a bolus feeding. So, I would also, after checking residual and everything, I would flush the line, and the amount you flush depends on the lumen size of the nasogastric tube and also the length. One way that you can determine the proper amount, especially in fluid-sensitive patients, is to gather a length of the same size tube and distill normal saline until you realize how many milliliters you're dealing with, and then you just go 1 or 2 past that, and that way you can clear the line and be set. So, I flush, then I add the prescribed amount of feed to the bag here. I'm going to use a pump for this demonstration. However, in the literature, I found that via gravity is preferred. I guess it's less forcible as the feed enters the stomach and reduces the risk of possible regurgitation. So I have this filled with my feed now. I'm going to put my pump together here, like so. Turn it on. I have a garbage can here. Perhaps a little basin. First thing to do is to prime the line hear that? I'm priming the line with feed at this moment. Consider it primed. And then I've flushed. Next thing I'm going to do is attach. And then I want to adjust my feed. I'm going to go feed volume to be infused. This being an infant, it's probably going to be somewhere in the neighborhood of 30 milliliters or so. So I'll set that. And like I said, for 30 milliliters, I mean, if we're going no more than 5 milliliters in 5 to 10 minutes, I'll just say that I'm going to do that over an hour. So I'll go 30 milliliters an hour and be set. Okay, so now my feeding is done, right? I come back, I'm done. During the feed, I didn't notice any signs of respiratory distress or any regurgitation, which was great. So now I'm going to turn this off, call it done. Have my supplies near me so that I don't reach across the patient. So again, I have sterile saline or sterile water, pardon me. So I'm going to turn the stopcock into the off position here. Remove the feeding. Draw up the appropriate amount of flush. And flush. Turn the stopcock off. And that's it.